Vascular retinal disorders. This is the fourth group of disorders of our retinal pathologies. And in this, what we are trying to study? We are trying to study diseases like CRAO, CRVO, as soon as I say the full form, central retinal artery occlusion, central retinal vein occlusion. Yes, we are talking about diseases which have their pathogenesis or start from some problem in the vasculature. Or if I say hypertensive retinopathy, everybody, we know hypertension is due to atherosclerosis, everybody, yes. So atherosclerosis is again a problem of the blood vessel which is leading to hypertension and in effect leading to retinopathy. Diabetic retinopathy. Diabetes is famous for causing macrovascular as well as microvascular complications, one of the complications being diabetic retinopathy. So in all of the diseases, the common point is that the abnormality is in the blood vessel. Yes. Now that abnormality may be a blockage or it may be a leakage, as we had said in basic FFA, everybody. But the abnormality is in the blood vessel. So when we read this group, if we are able to understand the pathogenesis of one disease, we are able to understand the treatment of one of the disease, we will see at last that common concepts apply everywhere, everybody. So instead of 5 or 7 diseases, this becomes a one group, everybody. Only the presentation slightly differ. They are also similar, same. The only difference is the name of the disease. Everything else you can catch a common thread and understand and read and retain for yourself. Yes. So now that we are talking about vascular disease, the first disease that we want to discuss is the main disease, everybody. That is diabetic retinopathy. Now, when we say diabetic retinopathy, there is nothing else to say. I know that I have diabetes, everybody, and that is why I have developed some changes. We are not talking about diabetes here. We are talking about a patient who is diabetic who has developed some retinopathic changes. Yes. So the first thing that I want to ask you is, what are the risk factors? Again, saying clearly risk factors for retinopathy, not for diabetes. In a patient already having diabetes, what is the risk factor for developing retinopathy? The first risk factor is duration of diabetes. I hope it goes without saying that the longer I have had diabetes, the higher will be the risk. Yes or no? Yes. So the duration is directly proportional to risk. If a patient 1 is there who has had diabetes for 1 year versus a patient who has had diabetes for 10 years, obviously retinopathy will be more likely in the patient with 10 years. This gives us two questions, everybody. What is the best time for screening of diabetic retinopathy in a patient with type 1 diabetes? And what is the best time for screening of diabetic retinopathy in a patient with type 2 diabetes? What are we trying to say here, guys? We are trying to say that we know already that the patient has diabetes. So we know retinopathy may develop. So when should we screen or when should we examine the retina to find out whether the retinopathy has developed? Diseased patient or it has not developed, apparently healthy? Yes or no? Screening is differentiation of disease from apparently healthy. So when should we screen in type 1? When should we screen in type 2? In type 1, you are saying after 5 years. I will write after 5 years, no issue. In type 2, you are saying as soon as possible. Okay. Now, why the difference in the answers, everybody? Because we know type 2 diabetes mellitus is usually asymptomatic, everybody. Old age, everybody, there are no symptoms. Even though we read polyphagia, polydipsia, actually there are no symptoms. This is almost always an accidental and incidental finding. One fine day you go and get your blood sugar checked and you find out it's 200. Oh, we need to start treatment. So we say that type 2 diabetes mellitus is almost always a chronic disease, a silent disease. So we don't know when it started. We only know the date of diagnosis, but we don't know actually when it started because of the chronicity, everybody, because of no symptoms. So we assume that if you are diagnosed with type 2, it may already have been 5 or 10 years. And after that, we may have diagnosed. So we say, don't wait. Diagnose retinopathy or screen for retinopathy as soon as possible. But type 1 diabetes mellitus is an acute presentation in young adults. Yes, the pathogenesis and the presentation don't have 5 years in between them. So we say retinopathy changes do not develop usually before 5 years. So wait for 5 years and only after that screen for type 1 diabetic mellitus patient retinopathy. I hope we are clear about this, everybody. Yes? Now, the second important risk factor is, all of us know, increased levels of hemoglobin A1C. Glycosylated hemoglobin, if it is under poor control, there are greater chances of diabetic complications like retinopathy, like nephropathy, and everything else. The third important risk factor is pregnancy. Moving on, everybody. Hypertension and hyperlipidemia. Comorbid conditions. Both affect the blood vessels by themselves. Yes. And lastly, diabetic nephropathy. So if you have kidney disease due to diabetes, you are almost always bound to have retinal changes also, everybody. So these are the 5 important risk factors. The most important risk factor, I will again repeat, is the duration of diabetes. Now that we know this simple information, everybody, let us understand how does it occur. What is the pathogenesis, everybody? Yes. So first of all, let us understand what are the biochemical changes. Okay. So what are the metabolic changes, everybody? Basically, diabetes is a metabolic disease at last. So what are the metabolic changes which are occurring at a cellular level which are leading to the damage of vessels, everybody? So we say biochemical changes can be, number 1, increased sorbitol accumulation. Just as we saw in lens, everybody, sorbitol pathway gets activated leading to cataract. There will be protein kinase C activation. There will be accumulation of reactive oxygen intermediates. I am writing ROIs. Also, there will be accumulation of advanced glycation end products. Without going into the detail of the biochemistry here, everybody, which I hope you have a very strong foundation of, these are the biochemical changes which are occurring, which are metabolic changes, which are leading to anatomical vascular damage. Okay. First of all, we need to learn the biochemical changes. Straight question is asked. Now we come to the important point here. Anatomical lesion. What is occurring in the blood vessels, everybody? Yes. So basically I can say that some blood vessel is getting damaged. Now the question comes, which blood vessel is getting damaged? Artery is getting damaged or capillary is getting damaged? Is it a macrovascular or it a microvascular complication? So we know it is a microvascular complication. So we know that the problem must be occurring in capillaries. The question that the examiners end up asking you is, what is the earliest anatomical pathologic change? The answer? You are saying, sir, hypoxia will occur. But how will hypoxia occur? I am talking about the anatomical change. I am talking about the damage. What is the damage? Is an aneurysm occurring? But if an aneurysm is occurring, how is it occurring? So the earliest change, anatomical lesion, we say loss of pericytes. I am not saying parasite, everybody. Please remember, it is not infectious. I am saying loss of pericytes. Now comes your anatomy, everybody. What is a pericyte? But as we know, a lot of our basics are weak, everybody. So what is a pericyte? Let us understand. Let me ask you, what is the difference between the vessel wall of an artery versus the vessel wall of a capillary? So an artery vessel wall, we say artery is thick, artery is strong. Its endothelium is multi-layered, everybody. Yes or no? But a capillary is fragile, if I can use such English. Capillary is fragile because the endothelium of capillary is a single cell structure, everybody. Yes? Now, because the epithelium of capillary is a single cell structure, it is fragile and it can keep on breaking. So what occurred? Outside the capillary, assume my finger is my capillary, there was another layer provided to give it protection, everybody. Yes? So that is the layer of pericytes. So what can I say? Pericytes are a layer of protection over my capillaries, which are helping it become strong so that it does not keep on breaking. Okay. Secondly, how does an artery pump blood, everybody? In the artery vessel wall, there are muscular tissues. So this muscle pumps, yes or no? But in capillary vessel wall, there is no muscle tissue. So how does the capillary move the blood forward? These pericytes are contractile cells, so they are contracting, they are pressing my capillary vessel wall and leading to pumping of the blood forward, everybody. Yes? So this layer of pericytes has two functions. Protective function and, as I said, contractile function. Now, this important layer of pericytes is getting lost in the capillaries. Due to that, what is occurring, everybody? Due to that, the protective function is getting lost. That means the capillaries are now fragile again. They are prone to damage. When they damage out, everybody, when their endothelium gets broken, there will be leakage of blood from capillaries. When there is leakage, everybody, along with blood, everybody, oxygen leaks out. So there will be hypoxia. Yes or no? Lack of oxygen to the retinal tissue. Hypoxia leads to secretion of, we have read in pathology, a very important factor, that is vascular endothelial growth factor, VEGF. And whenever VEGF is secreted, everybody, it leads to formation of new vessels. So there will be neovascularization of retina. And as soon as we see neovascularization, we say this is the hallmark for diabetic retinopathy. Okay, everybody. So I hope you understand all the changes are occurring, but the basic problem is, again I will say, the basic problem is loss of pericytes. Had the pericytes not been lost, all these changes would not have been able to develop, everybody. Yes? Now, what are neovessels? Pathology, again, everything, pathogenesis, we are discussing pathology, yes. What are neovessels? Are they normal vessels or are they leaky vessels? Yes, we call them leaky vessels, guys. Yes. So because they are leaky vessels, neovessels, as soon as they are formed, they again start leaking. Leaking leads to hypoxia, VEGF, more neovessels, more leakage, more hypoxia. So this becomes a vicious cycle. And that is why diabetic retinopathy is self-perpetuating, everybody. I hope you understand the basic pathology. If you understand the basic pathology, everybody, without even telling you, everybody, I can ask you to see these two words. And you already know the treatment. You have read the macular disorders just now, everybody. If there is leakage, we want to close the leakage. There is a pipe which is bleeding. We will do photocoagulation. If VEGF is getting secreted, just like in ARMD, everybody causing choroidal neovascularization, here there is neovascularization of the retina, the drug will be anti-VEGF. So based on the pathogenesis, if we understand, we already know the treatment options, everybody. And that is what we will use all throughout these vascular disorders. Right, guys? I hope we are clear about the biochemical and the anatomical changes. If yes, let us move on to the clinical features. Let us start by reading the classification of diabetic retinopathy. The name of the classification is ETDRS. The full form is Early Treatment Diabetic Retinopathy Study. That's the full form, guys. Early Treatment Diabetic Retinopathy Study. ETDRS has divided diabetic retinopathy into two stages. Number one, NPDR. Secondly, PDR. NP means non-proliferative diabetic retinopathy, obviously, and P for proliferative diabetic retinopathy. Okay, everybody? No confusion? Now, if I want you to understand these two stages, I will ask you to focus on English. Proliferation, that's the only word which differentiates these two stages. Proliferation is occurring. What do you mean by proliferation? Proliferation means something new growing. What new is growing here, everybody? We have just now read in the pathogenesis, everybody, neovascularization. What are we trying to say through the nomenclature? If there is neovascularization, it becomes PDR. If there is no neovascularization, means no proliferation, it becomes non-proliferative NPDR. That means there is one word which differentiates both these diseases, neovascularization. That means as a clinician, my job is as simple as finding neovessels. If I'm able to find neovessels, I classify as PDR. If I can't find any neovessels on the fundus, when I'm doing my ophthalmoscopies, I classify it as NPDR. Yes. So let us first of all see the sign of PDR. We already understand what is the sign of PDR. Yes or no? The sign of PDR is neovascularization. Okay. This can be of two types. NVD, NVE. What is NV? NV is neovascularization. D for disc. E for elsewhere. So we are saying neovascularization can either occur at the disc or elsewhere. How do we define NVD? Neovascularization at the disc or within one disc diameter. Either at the disc or within one disc diameter. Elsewhere, anywhere else in the retina, near the macula, near the ora serrata, in the periphery, NVE. Okay, we know the sign. But how do we identify this sign? On examination. What will I see on examination? Understand, everybody. How do we differentiate between a normal vessel and a neovessel? A normal vessel is supposed to be straight and branching pattern like this. This is a normal vessel. But a neovessel does not appear like this. Neovessel appears something like this. We say on examination there is a tortuous tuft of vessel. Again, pathology, everybody. We have read this. Now, we have seen a tortuous tuft of vessel. But because this is a vascular disorder, we can do which investigation, everybody? FFA. Yes. So on FFA, how will this appear? As I explained FFA to you, everybody, wherever there is blood, there is fluorescein dye. So now in this tuft of vessels, there is a lot of blood. So a lot of dye will collect. So will they be shining more or shining less? Meaning what, everybody? Meaning on a FFA image, there can be two types of lesions. Either a hyperfluorescent lesion or a hypofluorescent lesion. Hyperfluorescent means which is shining. Yes, white colored shining. Because there is some blood, as I showed you, leakage spots, everybody. Yes, because there are leakage of blood occurring there, the blood is accumulated, the dye is accumulated, pooling or leakage, everybody. That is why that area will shine. Similarly, I can say these are leaky vessels, everybody. These are tortuous vessels. A lot of dye will accumulate. So on FFA, these areas will be hyperfluorescent. Am I making myself very clear here? Wherever there is blood, there is dye. Wherever there is dye, they are hyperfluorescent. Okay, everybody? What will be hyperfluorescent? We will see in a while. Okay? That is about our PDR. Neovascularization, how will we see on examination and what will be FFA? Do we need to see photographs for this? Yes, we need to. Let us see. Let's see this photograph, everybody. This wide big circle is made already to help you. If it doesn't help you, let me see the anatomy. This is my optic disc. From the optic disc, you see normal vessels straight and branching going out. Yes or no, everybody? Straight and branching. You can see all these vessels. But if I focus on this tuft of vessel number 1, tuft of vessel number 2, everybody, can I see that this is a tuft? Can I see that this is a tuft of vessel? Making your life very easy. Making it a case of neovascularization at disc. NVD. Okay, I'll just rub the markings for you, everybody, so that you can see these images again. As soon as I see this, am I able to see on the disc neovessels, a tuft of vessels, everybody? Again, everybody see this here. Yes or no? And that is how easy it is. Or that is how easy it is in this image. Let us see another image, everybody. An FFA image. So everybody, as you can see, this is a fundus fluorescein angiography image. In this image, my only question to you is whether it is a case of PDR or NPDR. Whether you can see any neovascularization, yes or no, that's all. Let us try to find a hyperfluorescent, a whitish area which has some tuft. Can we find anywhere, everybody? Let me divide this photo into 4 zones and ask you which zone is it in? 1, 2, 3 or 4. Can you find neovascularization in any zone? 1, 2, 3 or 4? I can. Let us carefully see this, everybody. I am also seeing it carefully, everybody. It is not as clear as the other photo. It is not as big a neovascularization. Yes, some of you have been able to find in zone 2. If not, everybody see, focus here, focus at my circle. Everybody see carefully. This is my normal branching vessel going, everybody. But in this area, it forms small tufts like this, everybody, if I can say so, looking like a finger or a fan, everybody. Yes, this is a small vessel going here, everybody. This is neovascularization. This is PDR. There are lots of other things visible. Yes, I know there are lots of other signs visible. But as I said, I am bothered about what, everybody? I am bothered about whether I can see some neovascularization or not. Right, guys? Done? Now, let's move back to our classification. We are done with PDR. So now let's move on to NPDR. In NPDR, we are not being able to see neovascularization. That we know. But what are the other signs? So let us say A. What is the earliest sign? What is the earliest sign here, everybody? The earliest sign, yes, is microaneurysms. Microaneurysms. Now, what are the aneurysms? We already know, everybody. Aneurysms are outpouching. Yes? So, on examination, how will it be visible to me? Let me draw a diagram and explain it to you. Let's say this is a blood vessel which was red in color. Now there is an outpouching which is also filled with blood. So what will I see? Along the blood vessel, I will see a red dot or I will see multiple red dots. Yes or no? And these will be microaneurysms. So small red dots, everybody. So can I say on examination, tiny small red dots? On FFA. On FFA again, everybody, the dye is there in the whole blood vessel and then the dye is going into these outpouches also. So what will I be able to see? Tiny hyperfluorescent dots. Yes or no, guys? Yes. Tiny hyperfluorescent dots. Very easy, simple. Now also what they can ask you or what they do ask you is, which layer are these abnormalities seen in? So microaneurysms are seen in inner nuclear layer. Inner nuclear layer. Okay, everybody? Now let us see a photograph of the microaneurysm. Same photograph, everybody. FFA photograph in which we saw neovessels. These were your neovessels. Can you see some microaneurysms? Everybody see all this. See here, down here, microaneurysms. There is a blood vessel along that there are small dots. See in all this area, everybody. All these are microaneurysms. Small dot-like lesions. Here also. Here also, everybody. Everywhere you will see numerous microaneurysms. I hope we are clear about this. No confusion. Now, another important sign, everybody, sign B I can say, of NPDR is hemorrhage. Self-explanatory, everybody. Leakage is occurring, so hemorrhage of blood is occurring. This hemorrhage can be of two types, everybody. One is flame-shaped hemorrhage and the other is called as dot and blot hemorrhage. Okay, flame-shaped because it is long and thin. This is found in which layer? Superficial nerve fiber layer. Dot and blot is deep. It is found in outer plexiform layer. I don't think I have to explain you on examination. You will see a red colored collection. Yes or no? No, na. On FFA, that's all I can ask you probably. On FFA, I've beaten around the bush so much, everybody. This is hemorrhage. Blood will collect. Fluid will collect. The dye will pool here. So they will be hyperfluorescent. Yes, sir, we know. I know, you know. Hyperfluorescent areas. Then everybody, moving on to the next sign. exudates. What are exudates, everybody? Exudates are lipid deposits. In which layer? Outer plexiform layer. Lipid deposits in outer plexiform layer. Now we are talking something apart from blood here, everybody. Yes? So if I ask you on examination, how do they appear? As soon as I think lipid, I think of oil. Yes or no? Oil is what colored, everybody? You must have poured oil in your homes, everybody, sometimes while cooking, sometimes at least. Yellowish color, yes? So that's what I say. Yellowish, irregular deposits. Yellowish, irregularly shaped deposits. What about FFA? Very simple concept. I hope you understand. Let's say this is my blood vessel. Over this blood vessel, I have an exudate. Okay? Now everybody, when I do FFA, the dye will be here, the dye will be visible here. But at this spot, everybody, there will be no dye visible because it is hiding the dye. So this will appear as a dark area. So can I say on FFA, this will be a hypofluorescent area? Yes or no? I hope you understand, because this is hiding the fluorescence. Yes? Let us see an image again, the same image. In this same image, everybody, if I redraw this circle, this was my neovascularization. And if I show you this, see this green circle carefully. See this blue arrow carefully. What do I see? I see a small hypofluorescent area. Yes or no, everybody? Here again I see some hypofluorescent small areas. That means this must be, maybe, must be nahi kahenge, maybe this is a case of exudate. Yes or no? Query exudate. I hope we are clear about this. How do hypofluorescent areas look like? Please remember, this is not hypofluorescent. This is your macula. This is not hypofluorescent. This is macula. Okay? Now, moving back, everybody. Next sign. Cotton wool spots. Cotton wool spots are sometimes also called as soft exudates, though this is kind of a misnomer, because as soon as you hear exudates, you think about lipid deposits, but they are actually not lipid deposits. They are collections of neuronal debris. In which layer? Nerve fiber layer. Collections of neuronal debris in nerve fiber layer. See, anyways, our neurons are dying, but they are, every tissue is dying, yes or no? But macrophages will clear the dead tissue. But here, because there is retinopathy, the amount of neurons getting damaged are much higher than the amount of clearance by macrophages. So this neuronal debris is accumulating in the nerve fiber layer, everybody, and we are able to see that. How are we able to see that? So on examination, yellowish, large deposits. Okay, large yellowish deposits, and they have regular smooth edges, like a bundle of cotton. Yes or no? If you take out cotton, there is a bundle of cotton. It is large, it is light in color, and it is almost circular or regular edges. Okay, now let us see some images. Let us see this image, everybody. In this image, what sign can you see? What sign can you see? Optic disc, okay, blah, 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 okay. What are these yellowish deposits? Irregularly shaped exudates. Let us see this image. What can we see? We can see a lot of scattered hemorrhages. Yes or no? All these are hemorrhages. Along with hemorrhages, we can again see what, everybody? Some exudates. Are we clear here? No confusion. Let us see another image. In this image, what do we see, everybody? We see in these black circles a larger area of a smoother edge, yellowish color, and that is why they are cotton wool spots. And these two circles are showing you hemorrhages. What is also visible but not marked is neovascularization. If we see carefully, this is an area of neovascularization, right? That is how we look at a photograph and we are able to see all the signs. Moving back, everybody. Next sign is venous beading and looping, or I can say venous tortuosity. Due to ensuing hypoxia, continuing hypoxia, everybody, there is venous tortuosity, which presents as either beading or looping. Beading means dilated, constricted, dilated, constricted, dilated, constricted. Okay. Looping means the vessel will go like this, will loop over itself, and will become straight again. Okay. So these are venous tortuosities due to hypoxia. Pathology, basic pathology, everybody. Lastly, everybody, the last important sign of a case of NPDR, that is non-proliferative diabetic retinopathy, is known as IRMA. What is IRMA? IRMA is intraretinal microvascular abnormalities. Intraretinal microvascular abnormalities. What are we trying to say? We are trying to say, let's say, this is my optic disc. These are my blood vessels. Let's say there is some leakage occurring from this blood vessel. Okay, leakage. Due to that, the area in front of this will become hypoxic. So, the other blood vessel will form a small shunt vessel to this area. Okay, everybody? And this is intraretinal microvascular abnormalities. These are not neovessels, these are precursors to neovessels. Okay, everybody? So, shunt vessels bypassing the capillary bed. If we see IRMA, we are almost always sure that this is going to become PDR in a little while, everybody. Yes? So IRMA is a dangerous sign in NPDR and it is a precursor for PDR. I hope we are clear about the signs, everybody, of a case of NPDR. Earliest sign being microaneurysms, then hemorrhages, then two signs which will cause hypofluorescent areas, exudates and cotton wool spots, then venous beading and IRMA. I hope we are clear about this, everybody. Two stages, NPDR and PDR. Again, I will say NP means non-proliferative, no proliferation, no neovascularization. Proliferative means vascularization. Now, the question comes into my mind, why have I divided it into two stages? What was the need of dividing it into two stages? I must have divided the two stages because of some difference in the treatment that I need to do in these two stages. Yes? So what are my treatment options? I will go back to pathogenesis. I have to stop the leakage. I have to stop VEGF. So I have to do photocoagulation. I have to give anti-VEGF drugs. But what do I do in NPDR? What do I do in PDR? So let's say there are three options, everybody. Number one, photocoagulation. Number two, anti-VEGF. And number three, obviously, glycemic control. Out of these three options, which ones are you going to do in NPDR? No. So I will say, remember it very easily in another way. NP means non-proliferative, or I can say NP means no problem. P means proliferative, P means problem. So all I am trying to make you learn here is NP is not good enough for me to institute any treatment. In NP, non-proliferative, no problem. All I do is ask the patient to have a better glycemic control and follow up. Okay, we know if the blood sugar levels are controlled, all this will stop, all this will get reversed, everybody. And we ask the patient to keep on following with us to be able to determine the progression or regression, everybody. Now, follow up should be done in how many months? Depends on the stage, everybody. So, NPDR can be divided into 4 stages: mild, moderate, severe, and very severe. Mild, moderate, severe, and very severe. Mild, we ask the patient to follow up in 9 to 12 months. Moderate, we ask the patient to follow up in 6 months. Severe, 4 months. Very severe, 2 months. Okay, everybody? So the follow up time depends upon the stage of presentation. Now, what is severe and very severe NPDR? How do we diagnose whether it is severe NPDR or very severe NPDR? So, severe and very severe are based on a rule, 4-2-1 rule. What is 4-2-1 rule? 4 quadrants of hemorrhage, 2 quadrants of venous bleeding, and 1 quadrant of IRMA. Okay, everybody? So what we are saying is, just like I divided a fundus picture into 4 quadrants, everybody. If all 4 quadrants have hemorrhage, or if any 2 quadrants have venous bleeding, or if any 1 quadrant have IRMA, these are the 3 conditions, 4, 2, 1. Out of these 3 conditions, any one is seen, then we have severe NPDR. But out of these 3, any 2 or 3 are seen, then we have very severe NPDR. Are we clear about this here, everybody? Yes or no, everybody? Done? So based on our classification of non-proliferative diabetic retinopathy, all we need to do is ask the patient to follow up and have a strict control over his blood sugar levels. Done, everybody? Now let's say we had seen neovascularization. That means the patient was a case of PDR. So now we had 2 treatment options. What are the 2 treatment options we have, everybody? Photocoagulation and anti-VEGF drugs. So let's write A and B. But no, it is not that simple. When I write A, I want to ask you, out of the 2 treatment options we have, what is the treatment of choice? Would you rather do anti-VEGF drugs or would you rather do photocoagulation? Think about it. Think about the pathogenesis. You will understand yourself. What would you rather do? See, everybody, if I give anti-VEGF drugs, VEGF will decrease. Okay. But leakage is occurring, leakage will keep on increasing, hypoxia will keep on increasing, and so time will come when your anti-VEGF action will become lesser than the VEGF getting secreted. So at last, we need to treat the base pathology. We need to be able to treat the leakage. That means we will do photocoagulation. Again, you are writing photocoagulation. But my question, where am I going to do photocoagulation? Obviously, sir, retina. We are talking about retinopathy. But where in retina? Are we talking about photocoagulation at the ora serrata? Are we talking about photocoagulation at the macula? Are we talking about photocoagulation at the optic disc? Where should we photocoagulate? Where should we photocoagulate? Think about it. Think about it. Think about the fact that we know PDR can present either as NVD or as NVE. NVE means elsewhere. Elsewhere means I know this neovascularization can affect any part of my retina. So should I photocoagulate my whole retina? Yes. That is the treatment of choice. Pan retinal photocoagulation. PRP. Pan retinal photocoagulation. Now we should already know through our various readings that for photocoagulation, the laser that we use, everybody, is argon green laser. Okay, everybody? I hope we know this. Please remember some simple points. Pan-retinal photocoagulation is done in multiple sittings. It is never done in a single sitting, everybody. And the most common side effect is visual field defects. Doing photocoagulation is like playing a video game. So basically, there are lots of video games in which you have a gun in your hand and you have to shoot everybody. Yes or no? Counter-Strike and all such. But if you don't aim everybody, what is going to occur? Visual field effect. So I am trying to photocoagulate a blood vessel, but what if my aim is deeper or shallower, everybody? I am photocoagulating some other area, energy is being fired. So what if I am photocoagulating my rods and cones, everybody? I am losing vision from those areas. So if not done carefully, everybody, photocoagulation can lead to visual field defects. Now, the second treatment, all of us, we already know, are anti-VEGF drugs. The names of the anti-VEGF drugs, everybody, we have discussed in ARMD. The treatment of wet ARMD was also anti-VEGF drugs, the ranibizumab, bevacizumab, brolucizumab, and aflibercept. Yes, I hope we all of know that. Now, my question, do we treat all cases of PDR? Do we do treatment in all cases of PDR? The big answer is no, sir, not at all. So please remember, treatment done only in high risk PDR. So what is high risk PDR? A, if neovascularization at the disc greater than equal to 1/3 disc area. B, neovascularization of the disc with vitreous hemorrhage. C, neovascularization elsewhere greater than 1/2 disc area with vitreous hemorrhage. Okay, everybody. So only under these three conditions are we going to treat PDR with photocoagulation or with anti-VEGF drugs. Otherwise, we are not treating this. I hope we understand. That means if I show you this photograph again, everybody, this FFA image in which there is a very small neovascularization, probably the area is not greater than half disc. Yes, that is why probably we are not going to treat it. I hope you understand, everybody. Yes or no? So that is all about the treatment of a case of diabetic retinopathy. But as we know, diabetes is famous for causing complications. So why should diabetic retinopathy be left behind? So a complication is causing further complications. So now what we are reading, everybody, are the complications of diabetic retinopathy. Okay? So let's read. Number 1. The first important complication is diabetic macular edema. Diabetic macular edema. Now, the whatever leakage is occurring is not occurring throughout the retina. Only the blood vessels surrounding the macula are getting abnormal, so they are leaking fluid, everybody. Yes? So, can I say this is due to leakage? Number 1. Number 2, everybody, if macular edema is occurring, macula, you are losing central vision. Can I say this is the most common cause of loss of vision in diabetic retinopathy? Or if specifically asked, what is the most common cause of loss of vision in non-proliferative diabetic retinopathy? The answer is cystoid macular edema. Why am I saying cystoid macular edema? Have we just now read cystoid macular edema, everybody, a little while back? We had read the risk factors. The risk factors were RUN for pride, RUNPRIDE, D for diabetic retinopathy. So when I'm writing diabetic macular edema, I'm actually talking about cystoid macular edema. I hope you understand what I'm trying to say here. Go link both the topics. Yes? Now, because there is leakage occurring, because there is loss of vision occurring, what would I want to do for diabetic macular edema? I would like to treat. Yes. So what are my treatment options? The question is, what are my treatment options? A, everybody, treatment of choice. As soon as I focus on the word leakage, leakage means photocoagulation. But will I do pan-retinal photocoagulation? No, everybody, we are talking about macular edema. That means I will do focal laser photocoagulation. Okay, focal, obviously. But we have other options. Think about cystoid macular edema. We had said we can use steroids. So if we have intravitreal triamcinolone, then it also becomes a treatment. Triamcinolone is a steroid. Intravitreal triamcinolone is preferred if ischemic maculopathy, if ischemia has developed, in a pseudophakic patient, or if patient has cardiovascular disease, coexistent cardiovascular disease, some kind of bypass has been done, the patient is on stent, the patient has a pacemaker, something like that, everybody. Yes or no? So in these three cases, we prefer giving intravitreal triamcinolone. What will be our third option? What will be our third option, everybody? Leakage is occurring. Leakage must be leading to release of VEGF. Yes. So our third option is anti-VEGF drugs. Anti-VEGF drugs are preferred if center involving edema. Center involving edema means within 300 microns of center of macula with foveal thickness. See, as soon as I say center involving edema, we are talking about fovea. The center of macula is fovea, yes? So we are essentially now here saying that we don't have macular edema. We have only foveal edema. So foveal thickness greater than 250 microns. Now the question is, if there is foveal edema, why am I not preferring the treatment of choice? Why am I preferring anti-VEGF drugs? See, answer I just now gave you. The most common side effect of photocoagulation is visual field effects. If I photocoagulate the fovea and by mistake I photocoagulate wrongly, I will lose which vision, everybody? I will lose central vision. I don't want to take a risk with my central vision, everybody. So whenever you are having some doubt, say no to photocoagulation, say yes to anti-VEGF drugs, everybody. I hope we understand this. Okay? Now, the treatment for macular edema again is not done in all cases. Treatment is done only if CSME, okay? CSME is clinically significant macular edema. Treatment is done only if CSME, clinically significant macular edema. So what is clinically significant macular edema? Retinal thickening. Due to edema, thickness will increase within 500 microns of center of macula, or exudates within 500 micron of center of macula, but if retinal thickening, I am writing RT, present anywhere. I hope you understand what I am saying. CSME, I am saying if retinal thickness is present within 500 micron of center of macula. Okay? So that means towards the center. Then we are treating it. Number one. Or number two, we are saying if exudates are present within 500 micron, but there should be some retinal thickening present. Whether it is present within 500, outside 500 meter, does not matter. Okay? Number three. retinal thickening or exudates greater than 1 disc diameter in size within 1 disc diameter of center of macula. In point 3, we are saying either you have retinal thickening or you have exudates. We have increased the area. We have increased the area to within 1 disc diameter. Within 1 disc diameter means within 1500 micron. I hope you remember 1 disc diameter is 1.5 mm, which is 1500 micron. But then if we have increased the distance, everybody, then the size of the lesion itself becomes important. So retinal thickening itself should be 1 disc diameter, or exudate should be covering an area of 1 disc diameter. I hope we are clear about this. That is our first complication, everybody, macular edema. Now, second complication, everybody. The second important complication of diabetic retinopathy is vitreous hemorrhage. Vitreous hemorrhage. Now, as soon as I say the word hemorrhage, everybody, the first question I always want to ask is, what is the source of my hemorrhage? Where is the blood coming from? Is vitreous vascular or avascular? We all know vitreous is avascular. There is nothing called vitreal blood vessel. So that means where is the blood coming from? Simple thing. This is my retina. This is my vitreous. Posteriorly, vitreous touches the retina. Anteriorly, vitreous touches the lens. Lens is also avascular. So the only vascular structure in contact with vitreous is retina. That means the bleeding must be occurring from retina. Yes? So can I say neovascularization of retina or the neovessels of retina? In diabetic retinopathy, we have neovessels. Neovessels are leaky vessels. Leaky vessels will leak their blood. Some of it will collect in the retina, but a lot of it will go out into the vitreous. Now, vitreous hemorrhage. Can I say, everybody, that this is the most common cause of loss of vision in PDR? See, I am specifically saying which stage, everybody? Loss of vision in PDR. Why, everybody? Proliferation, neovascularization will be seen in PDR. So more than macular edema, the more common cause of vision will be vitreous hemorrhage. Now, vitreous hemorrhage is occurring. It is causing loss of vision. I hope you understand why it is causing loss of vision. Vitreous is transparent. It allows light to travel through onto the retina. But when there will be accumulation of blood, you will see a red colored vitreous. It will stop the light. So that means we need to treat, everybody. Yes. So if it is a small vitreous hemorrhage, we can observe. Okay. But if it is a large vitreous hemorrhage, or if it is recurrent, everybody, then we have two treatment options. Either endophotocoagulation or pars plana vitrectomy. Okay, everybody. So if there is a small vitreous hemorrhage, everybody, which is probably not in your visual axis, we will give it time to self-absorb, everybody. Yes? We ask the patient to keep the head elevated, blah, 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 simple stuff, everybody, it will absorb. But if it is large, everybody, covering a large area, which is actually causing loss of vision in the visual axis, or if it is recurrent, then we have to treat it. Endophotocoagulation, go inside and photocoagulate, not external photocoagulation like we do in other procedures, or the better treatment is pars plana vitrectomy, cut the vitreous. Yes? Now, some other questions about vitreous hemorrhage, everybody. Question number 1. What is the most common cause of vitreous hemorrhage in adults? Let's say answer will be what you are reading, diabetic retinopathy. Okay. But if you are asked what is the most common cause of vitreous hemorrhage, and this word is written, young adults. See, when we are talking about young adults, we are talking about your age group, 20 to 40 years, or even my age group. I am below 40. Yes. So diabetes is not going to develop in us, yes or no? So the most common cause here is Dishum. Blunt trauma. Now, third question. Most common cause of recurrent vitreous hemorrhage is something called as Eales disease. Okay, everybody. These are the three questions that you need to be able to remember on vitreous hemorrhage, apart from the basic of vitreous hemorrhage that I have tried to explain to you. In diabetic retinopathy, there will be neovessels. In Eales disease, there are neovessels. In blunt trauma, where is the bleeding occurring from? Instead of neovessels, everybody, I can say normal vessels of retina. That's all. But the vitreous hemorrhage will always occur from bleeding of retinal vessels. If neovessels are present, they are more leaky. But if neovessels are not present, then it is damage of the normal retinal vessels. Yes or no, everybody? Done? Now, third complication, everybody, of a case of diabetic retinopathy is retinal detachment. Retinal detachment is the most common cause of blindness. Everybody, we were talking about loss of vision till now, but now we are saying blindness. I hope you understand the difference. Apart from this, everybody, retinal detachment has been discussed as a whole topic, so everything else will be discussed there. Last complication, everybody, is rubeosis iridis, which I mentioned before. If not, then please remember. Rubeosis iridis means neovascularization of iris. Yes. Why is neovascularization of iris occurring? That's the question. It is occurring due to oxygen demand by the posterior segment on anterior segment. Do you understand this line? Because my retina is progressively becoming hypoxic, everybody, it is putting oxygen demand onto the iris. Iris is the vascular tissue in the anterior segment. Iris is lending oxygen to the posterior segment, and in effect, it is getting hypoxic. Hypoxia, VEGF neovascularization. So, rubeosis iridis is not occurring due to problem in iris. That's the take-home message. Rubeosis iridis is occurring due to problem in the retina. Oxygen demand by the posterior segment. I hope we are clear about this, everybody. These are all the important complications that we need to remember in case of a diabetic retinopathy. And this is all about our primary vascular retinal disorder, that is diabetic retinopathy. Using the basics that you have studied here in pathology, that there is leakage, there can be anti-VEGF, there can be photocoagulation as the treatment, the fact that hemorrhage will occur, the fact that neovascularization will occur. If you keep all these facts in your brain, everybody, you will be able to read all the other vascular disorders. All the vascular disorders almost follow the same line of process, everybody. Let's see the second disorder now.